Okay. All right. So this epic tale starts with a discovery. So in the 1950s, basically, there was a guy called Edmund Cornfield. He worked for Eli Lilly and Company, and his life's mission was to find new drugs. In 1952, he starts looking around for other sources of diversity to try and find things that might be useful as antibiotics. Many of you will know. I see there's a comment in the chat about unable to hear. I hope others can hear. If you can't, just
Yeah,
let me know.
we can hear you fine.
Cool. All right, thanks. So in 1952, he was looking around for other ways to find antibiotics. Many of the antibiotics in that era were coming from other fungi or other bacteria, and so he thought this was a good source of looking. So he sent out a whole bunch of sterile vials to his friend. He'd met a missionary friend in the World War II, and his friend was based in Borneo, basically, where that picture in the map is. And he sent back a whole bunch of soil samples. Off the beaten track was the suggestion, and he did find them. And in those soil samples in Borneo, they managed to find a substance back in Indianapolis that was produced by an organism in the soil called Streptomyces orientalis, as it was then. It's now got a different name, but at the time it was Streptomyces orientalis. That's what they found. And they found that it produced the substance which they labeled compound 05865. Very, very impressive name for a chemist, and sadly typical. Nothing that would excite any of us, but this compound they tried on a whole bunch of bacteria. And it turned out, because remember in the 50s, the big issue there was penicillin resistance for the staphylococci. Staphylococcus had started off as being penicillin susceptible. Within really a few years you were starting to see a huge amount of penicillin resistance. So they were looking for something that would work against the staphylococci that were penicillin resistant. And they found this substance, 05865 in the compound. And when they gave it to staphylococci, seen pictured on the right, it nuked them and killed them all. And this was incredibly impressive to them, and because they had finally found something that would work against the staphylococci. But they were a bit nervous about what would happen to the streptococci and what would happen to penicillin. So they tried it via this idea of serial passage. So they took a culture of Staph aureus. They gave a little bit of sort of low-grade amount of the substance, and then they would wait and see what grew, and then they would take a few of those staphs and use it with a little bit more of the stuff. And they went through this process 20 times to see if they could evolve resistance effectively to it. Because, of course, this is exactly what had happened with penicillin just a few years before. And when they took those 20 cultures, what happened is it nuked it. And towards the end, it lost a little bit of its efficacy, which suggested you would eventually get resistance, but much less so than with penicillin. So penicillin resistance over those 20 serial passages increased by 100,000 times, but there was only a modest kind of 4 to 8 times increase in resistance from this compound 05865 with a great name. So that gave them some sense that this was going to be an antibiotic that would last and wouldn't fall prey, at least with Staphylococcus, to the same problems that penicillin had had. So they tried it in some animals, and then that looked very good and very promising in animal. And then they tried to give it to humans. Now, this was a challenge. And of course, in the 50s, the standards of clinical trials weren't nearly as good as they are at the moment. So really what they did is they just put out word across Indianapolis to house officers working at several hospitals saying, do you have a patient who might benefit from this substance? And they found a guy eventually. So for the first few weeks, they couldn't find anyone because the patients were nervous about taking an unproven drug, understandably. But eventually they found a guy who had developed a severe staphylococcal infection of his foot following surgery as a complication of surgery. And all the available antibiotics alone and in various combinations that they hadn't improved him, and they could actually show in the lab that the staph was resistant to all these other known antibiotics. So they recommended this. The quote here comes from a book describing the early days of vancomycin. They recommended amputation. We told him about this new antibiotic, and he said, just as any of us would have said, anything that might save my foot. So then they gave him this compound, which, like I said, had not been tried in humans yet. And in 5 days, the heat was disappearing out of his foot. His white cell count was dropping, and the exudate of his wound was less. During the next 7 days, the staphylococci disappeared from the wound, and his foot was free from any sign of infection. Then we ran out of 05865, the person writes. because they were really, you had no idea. By the way, the dose here was 100 milligrams 4 times a day, which will give you some sense of how little they knew about the dosing at the time. And while we held our breath, he continued to improve, though, despite them running out of treatment about a week or so in. And he left the hospital with an intact foot. So this was the first case it was ever used in humans, and it was successful. And then they used it on a few more humans, and in fact, the FDA fast-tracked this approval as it was an emergency to use something, to find something rather that could be used for penicillin-resistant staphylococcus. And apparently, the guys in Eli Lilly who manufactured this, and Edmund Kornfeld specifically, the phone was ringing off the hook the entire time. So he was very in demand from people all around the country who'd heard of this new compound. So they needed a name. And the name they gave was vancomycin. And the word comes from vanquish, because it would vanquish the penicillin-resistant staphylococci, and the mycin from the streptomyces of its origin. So it was effectively vancomycin, which they chose. And that's where the name comes from. It's a little bit lame. There is, of course, the famous infectious diseases emoji game, which has also named it after the Vancomycin, which I'm sure you'll appreciate is a much better way of naming things than naming it after vanquish, which seems to be tempting the antibiotic world to learn resistance. How does it work? Remember how bacteria work effectively. They've got a cell membrane like all of us, but they pack so much stuff inside that cytosol that it's massively osmotic, hyperosmotic. So in other words, if water gets in, it would just rupture unless you basically buttress the surrounding of the bacterium with a cell wall. The cell wall depends, obviously, gram-positive, gram-negative, but the gram-positive one in particular is laden with a stuff called peptidoglycan. Peptidoglycan here, it's shown on the right. And on the right, you can see it's got these NAM and NAG residues. They stand for N-acetylmuric acid, etc. But it doesn't matter. But these little balls that go together, and they make like a long chain of rope, which is fine. But if you think about it, you need to make a mesh. So you need to cross-link those ones. So in other words, you need to take those individual strands and put cross beams to give it much more structural sense, structural strength rather. And this is the kind of step that vancomycin inhibits. So if you look at this happy picture from Wikipedia with these NAM and NAG residues and these different colors at the top here, the idea is that vancomycin binds to the end of those oligopeptides sticking out the edge, which would otherwise be used to fuse together to form a crosslink. And then it prevents them adding more NAM and NAG to the end of it. And it also prevents the cross-linking. So you basically have sort of chain termination, which is technically this transglycosylation, doesn't matter, but it's the elongation of the chain, and also prevents the cross-linking of that chain, which is known as the transpeptidation. Now, I will see if I can show you a video of what this looks like, just because it's pretty dramatic. I've shown it once before in a different thing. Let's just see if I can get it to go from here. I'm not sure that it'll work. Let's give it a bash and see. It doesn't seem to like the video, but you can see the difference effectively on the right versus the left. On the right this is actually in response to penicillin, but it's the same concept. On the right is these intact bacteria. I think these were E. coli. On the left are these things that have just lysed. They've just exploded, basically, because the inhibition of this formation of the cell wall basically leaves these things osmotically fragile. And in fact, it can kill them even when they're not dividing all that frequently, because the cell wall has to keep being updated, kind of constant war of attrition. So even if the bacteria aren't dividing, it'll still eventually get them. And they just rupture, literally. The water flows in, and basically the cell wall can't prevent that, and it just ruptures. You can see that on the left. There's sort of like ghost-like impressions of where the bacteria were. Okay. So what does it work against? It works against pretty much everything that's gram-positive. There's one or two trivia questions for things that aren't gram-positive that it doesn't work to, but pretty much everything gram-positive. It's survived a long time, much longer than most antibiotics in terms of an active agent. Occasionally, you get some enterococci that are resistant. We know them as VREs, the vancomycin-resistant enterococci, mostly Ephecium. And staffs very, very occasionally learn this vancomycin resistance too. They learned it from the enterococcus. They actually can share that. And how it happens is effectively where the vancomycin binds, that the two alanine residues at the end mutate to a different one. So it's alanine lactate, for example, then the vancomycin can't bind. That's for the vancomycin resistant enterococcus. For Staph aureus, there's also the sort of VISA, the vancomycin intermediate resistance, which is a different mechanism. But in essence, this is the concept behind it. So it's pretty much most gram-positives are still susceptible to it. And again, we do have VREs occasionally, but very little staph that's resistant to vancomycin if you look nationally and locally. The quick version of its pharmacokinetics, because this turns out to be important in terms of how you dose it. You really can't absorb much from the gut, which is why you can pretty much only use oral vancomycin for C. diff, which is in the gut. And in fact, the concentration of drug in the gut is enormously high in that perspective. You don't even really, I mean, the usual dose of 125 milligrams, sometimes in the guidelines says up to 500 milligrams, for example, in severe cases. You, in fact, really from a pharmacokinetic perspective and pharmacodynamic perspective, you really don't need more than about 125, I guess, as long as it's getting to the area. So you really can't give it orally, unfortunately, apart from for C. diff. And similarly, if you give it intravenously, you can, it doesn't work for C. diff, doesn't really cross the gut in either direction much. It basically gets everywhere if you squint a bit. It's not bad. I mean, nothing gets into the head through the blood-brain barrier well, but of the drugs that have to try, it's among the better ones. So it's, certainly if you give a high enough dose, it'll get there. And gets pretty much everywhere. There's no big region in the body where it doesn't get. You don't really metabolize it either, which is also interesting. So it's a very simple drug in this sense. And so it really just gets excreted mostly unchanged in the urine by filtration. So it's not via excretion, active excretion, for example. It's just really passively filtered and then out it goes in the urine. And the half-life in a person with normal renal function is about 4 to 6 hours. So a sort of moderately long half-life by antibiotic standards. But again, obviously, the key thing there is that you're seeing that it's because it's really not metabolized and it's excreted pretty much unchanged in the urine. Its excretion is going to be heavily dependent on the patient's renal function. It's the only way for the drug to leave. So that's important. What sort of toxicities does it have? This is known in most of the literature on the left there, as you can hopefully see, as red man syndrome, sometimes called red person syndrome, or the Americans prefer vancomycin infusion syndrome because they're worried about the phrase red man with their historical context. But for most of the literature, it's still red man syndrome. And really what happens here with vancomycin is that if it's infused relatively quickly, you get mast cell degranulation, it releases histamine, and then you get a sort of systemic histamine reaction. Vancomycin always makes mast cells activate, but if you infuse it slowly enough, that activation is low enough that it doesn't really cause anything. But when you do it very quickly, so if you infuse it too quickly, most textbooks would say really 1 gram an hour is the fastest you can do. So if you've got, say, 1.5 grams to deliver, you need to be giving it over at least 1.5 hours. If you do quicker than that, then you run the risk of this red man syndrome, which can clearly affect women too. That patient on the left there is a patient we saw at our hospital in orthopedics ward. We were called to see her for a staph infection. We went down to see her in the afternoon, and she was having this reaction in front of us, actually. No one had noticed. So we did what you're supposed to do. We stopped the infusion at the time, because obviously it's just an infusion rate thing. So we just turned it off, gave her some antihistamines, and it settled very, very quickly. Her symptoms resolved within about half an hour. And the key thing here is it's not an allergy. When you see this reaction, you don't want people to say, oh, you're allergic to vancomycin. You can actually have an allergy to vancomycin. It's very, very rare, though, and it doesn't look like this. So this is just a red man syndrome from infusing too quickly. So you can prevent that from infusing it more slowly. The other big side effect, of course, is renal dysfunction. And that's caused actually by the drug accumulating around the proximal tubular cells where they get filtered through, remember, and they can cause apoptosis of those cells. You really just damage the cells directly. The prevalence of this varies hugely in the studies in the population by all the things you would think it would vary by, but it's anywhere from 5 to 40, in fact 43% in the one big systematic review. And it's pretty much dose dependent. So in other words, if you give less drug, you get less renal dysfunction, which stands to reason. But clearly also the chances are influenced if you have nephrotoxic drugs, like if you're on aminoglycosides too, and if you are very sick, and if you have pre-existing renal failure, all the sort of things you would think would push it up towards the top of that range rather than somewhere near the bottom of that range. So that's the drug. And now how to dose it, which is hard. Right. And I'm going to cover mostly just this from an adult perspective. Much of this does translate to pediatrics, but the target's a little bit different. And then there's some nuances there, which I'm certainly not an expert for pediatrics. So I'm going to really focus this predominantly on adults. This is a kind of classic idea of what you need to understand by a drug concentration curve. On the bottom is time. On the top is concentration, makes straightforward sense. So in other words, the higher the concentration, the higher up that graph it goes. When you give a drug intravenously, what happens is it shoots up very quickly, and then with time, it decays as you excrete it. And most drugs are exponentially excreted. In other words, they follow this kind of that shape curve there. So in other words, the body excretes a certain percentage rather than a total amount at each unit of time. So that's the kind of standard look for how a drug concentration curve would look. And that allows you to say a few things relatively straightforwardly. You can look at the peak concentration and you can measure this. So you get a whole bunch of interns who you can underpay and healthy volunteers, as they're called in the literature, and then you can pay them a little bit and you give them this drug, and then you can watch what happens to their concentrations. You take blood samples every few minutes and you can basically plot these curves for any new drug that comes. And of course, then you can try it in other populations, but many of them are started off, of course, in healthy volunteers. So you can say this is the peak concentration. You can wait until you would next have to dose the drug, and then you would measure the trough concentration, which is just before the next dose. And then you can calculate this area under the curve. And that's really the shaded area there. Now, that's hard to calculate with simple maths because of the shape of the curve, but you can do it with calculus. It's actually not that difficult. And the concept is anyway that you can get the peak, you've got the trough, and you've got this area under the curve. And then you relate that in some way. So those are characteristics of the drug. And then you relate that in some way to the characteristic of the bug, which is its minimum inhibitory concentration, MIC. Which really just is it's usually MIC 90, so it's the concentration that would prevent or kill 90% of the drugs from dividing. So in this graph, we'll put it over here, but clearly a very susceptible drug would have a low MIC and a very resistant one would go somewhere even higher. So you're relating the characteristics of the drug in some way to the resistance pattern of the bug. And that makes sense. And then pretty much for every drug, more or less, there's one of three things that correlates with efficacy. So you don't know this if you develop a new drug. You can measure these things on the curve, and you can measure the MIC of any bug to this new drug. But then you have to work out which of those things on this graph correlates best with efficacy. In other words, what do I really have to target if I'm going to give a patient this drug? And they turn out to be pretty much one of three ways. You can look at the time above the MIC. And you can see it over there, that middle section there is all above the MIC. You can look at the area under the curve, relating it to the MIC. So in other words, each time relating it to the susceptibility of the organism. Or you can look at the peak of concentration relating to the MIC. For most drugs, and vancomycin's included in them, it's this middle one. So when we talk about area under the curve, we're just saying it's the total amount of drug. It matters less how much time above the MIC the drug concentration spends, and it doesn't matter as much what the peak concentration is. It really matters just how much of the drug the patient gets in this drug period, let's say in 24 hours. And that's what we want to really maximize in vancomycin. We want to maximize the amount of drug relating that to the MIC that the patient gets. It doesn't really matter whether it's how much time above the MIC or what the peak is, at least as much. And then you do very fancy experiments, and eventually from about 50 years of data, some of it observational and dreadful, and some of it much more recent and better, it turns out that what you really want is the area under the curve to be 400 times whatever the MIC is. So fortunately, most MICs are one or less for things like staph to vancomycin. So really means for most drugs, you really want for most bugs, you really want the area under the curve to be 400. Now, I show this because turns out it's a very important number. But also, if you get it above that number, it also seems to prevent resistance from developing. And those two factors are related. In other words, if I can get the amount of drug to be 400 times the MIC, then I get maximum effect. So if I go to say 600 or 800 times, it doesn't give you better effect. But if I get less than 400, the patients don't do as well on average. Obviously, you can imagine the range in each individual trial, and this number is somewhat of a sort of approximation of many trials, but you get the general principle that it really needs to be about 400. If it's 400 times the MIC, then you're doing great. And the MIC, fortunately, is usually one or less. So if you use one, it means really we're just looking at an area under the curve of 400 micrograms per mil. Does it matter? It does, but there's another thing, is that the toxicity really starts shooting up above about 600. So this is a nice meta-analysis that actually looked at about, say, 650, as it turns out, but they gave a plus minus 100 for each. And what it shows, really, if you're not comfortable looking at these forest plots, that's really the summary version of each of these. These are for measuring it in the first day and measuring the second day. It doesn't matter. The point is that that diamond there in the middle favors basically any MIC less than 650 for nephrotoxicity. In other words, if you increase your MIC above, sorry, your area under the curve more than about 650, you get a lot more nephrotoxicity. So if you keep it below 650 in this one trial, they ended up with about a sort of, what is that, 65, 64, and 55% reduction in nephrotoxicity, respectively. So it's a big difference. It also matters whether you're looking, for example, at if you're trying to measure a trough directly, or if you're measuring the area under the curve. And we'll come back to this because this is an important point. Turns out that if you actually target the area under the curve, you probably do better. And the bottom line is many clever pharmacologists have piled all of this information together, and it seems like we finally got something like a therapeutic window. This is a guideline that came out in 2020 where they piled the Infectious Disease Society of America together with the American Society of Health System Pharmacists, bizarrely, Society of Infectious Diseases Pharmacists, the Pediatric Infectious Disease Society. They got everyone together. And the consensus guideline was that this is roughly the window you want. You want an area under the curve of between 400 and 600. Less than 400 is not great for efficacy, so you really want to achieve 400 to achieve the best killing you can. And more than 600 seems to be correlating with a much higher rate of nephrotoxicity. In other words, if you're pushing it above 600, well, remember I said once you hit 400, you're not really doing any better with the killing. But above 600, you're really just increasing your nephrotoxicity unnecessarily. So you want in most patients to get this area under the curve of between 400 and 600. That seems to be the best that we can do in terms of the knowledge that we have based on 50 years of pharmacokinetics and pharmacodynamic studies. That's the one and most important concept. You may be thinking, how on earth, okay, fine, how on earth do we get there? That's where we come to monitoring. So the question really is, how do we target that range? It's all very well to say, clever pharmacologists have said you need between 400 and 600 for air under the curve, but how do we target that range? Well, the first point about dosing is that you need to probably give a loading dose for vancomycin. This is the idea of half-lives, and this is important about when to measure levels, etc. This graph really applies to every drug, almost every drug. So the idea behind this is basically in a dosing interval, every half-life, you basically get to this sort of curve. So in the first half-life, you'll get about 50% of the steady state concentration. After 2 half-lives, you get about 75, then 87.5, 93.75. So basically, after about 4 half-lives, you're pretty much there in terms of steady state. After that, your drug concentration is not going to change much in terms of, say, trough concentration, even if you keep giving the drug. And that's because, again, the body excretes a certain percentage rather than a certain amount. And eventually, when you've got enough drug in your body, the percentage that you excrete equals the amount that you give, and then you end up with a drug concentration that doesn't change much. So that's the kind of steady state. So the longer the half-life of a drug, the longer it'll take to reach steady state, but you will still, so in other words, if each drug, say, takes about 4 half-lives to get to about 90-odd%, then if your half-life is half an hour, then clearly you'll get to steady state a lot quicker than if your half-life, say, a day, because in each time you have to wait for 4 of those half-lives to get there. So if your drug has a long half-life, and also if you have this very narrow therapeutic window, so in other words, if you really can't get too far above or beyond or below it, then you probably need a loading dose. So for example, this is a drug which you can think of, say, as amoxicillin. These are just conceptual examples where you can target, because you have such a wide therapeutic window with these drugs, you can target somewhere in the middle. And really from the first dose or two, you're already getting pretty good activity. Whereas if you have a drug like vancomycin, which has a teeny tiny therapeutic window, then you're not going to get there until 4 half-lives. And if your drug has a long half-life, well, then you're going to wait a long time. And unfortunately, remember, for vancomycin, it does have a fairly long half-life by antibiotic standards of 4 to 6 hours. So if you think of it, if you call it 5 hours to get somewhere in the middle, if it's going to take, say, 4 half-lives to get to roughly your steady state level, then you're going to be waiting for 20 hours, in other words, nearly a day, until you start getting the activity that you need. So you can't wait that long in any severe infection. This, for example, gives you an idea. This is comoxiclav, Keftrax, and vancomycin. Comoxiclav, very short half-life, Keftrax, quite a bit longer, but the therapeutic window so wide that you can target somewhere in the middle there, and you don't really need a loading dose. There's some nuance to this too. It's also about dosing intervals, but for now, this is okay. Whereas vancomycin, unfortunately, has quite a long half-life, but a very narrow therapeutic window. So you pretty much do need a loading dose. Does it help though? I mean, it's very well to make the point that this is a theoretical thing. Does it actually help in the real world? Well, there was a systematic review that was done 2 years ago now, looking at loading doses. And they were able to show that there were really higher rates of achieving the target therapeutic concentrations. If you give a loading dose, you got a better responses judged in the studies that looked at either the clinical state or negative blood cultures. And you also had no increase in nephrotoxicity overall, despite giving these loading doses. So the answer really is you should be giving them, at least for any patient who you can't wait for the better part of a day to start seeing this sort of activity. So the ones who are severely ill. If you have a minor skin and soft tissue infection that is MRSA that you want to cover, for example, it's probably not needed. But if you have a bacteremia and endocarditis or something like that, you do need it. The loading dose is given per kilogram, so it's 20 to 35 milligrams per kilogram in the latest guidelines. Your loading dose in your favorite app or favorite formulary will be a slight variation on that. Some are 25 to 35, 20 to 30, but the range in the latest guidelines is a bit wider, so anywhere between 20 and 35 milligrams per kilogram. You base it on the absolute body weight. So in other words, you don't calculate things like ideal body weight, etc. It's really just on the exact, so what the weight that the patient has when they stand on a scale, that's the weight you use. Shouldn't exceed 3 grams though, because at that point you just get toxicity without much more efficacy. You've got to be careful with the rate of infusion. Remember, I told you about the red man syndrome, and that's really particularly problematic, obviously, for the loading dose. So that's where in clinical practice, we see people run into trouble, because the usual dose in standard infusions of, say, a gram and a half, most of the nurses remember, okay, it's over about an hour and a half. But these loading doses have to go much slower effectively because you're giving so much more drug. So be careful of that. You don't adjust it for renal dysfunction. This is the other mistake we often see with loading doses, where frightened nephrologists will look at this and say, the patient's got horrendous renal function. We can't, and yet you've given this patient 2 grams of vancomycin. That's horrific. The job of a loading dose is really just to think of it as fill up your volume of distribution, if you like, and get you closer to steady state. It doesn't impact on renal function. We even saw in the systematic review that it didn't increase that. But even if it did, you would still have to get there because your job is therapeutic dosing as quickly as you can. You really can't wait another day or two. Nothing is bad for renal dysfunction as a patient with untreated staphylococcal bacteremia. And then when do you give the next maintenance dose? A very common question we get. So I've loaded them today. When do I give my next dose? Well, it's whenever you would normally have dosed. So if the renal function is normal, most people would give vancomycin every 12 hours, at least as a start. And so your first maintenance dose would be 12 hours after the loading dose. So basically think of a loading dose as just a much bigger initial dose, but the dosing interval between doses stays the same. It won't surprise you to know that the dosing interval is very heavily dependent on the renal function. So we've given a loading dose now. Now you have to write up the maintenance dosing, and that's a bit of a guess. Why is it a bit of a guess? Because unfortunately, you can't get away from the need for drug levels. So this next maintenance dose is here about 15 to 20 milligrams. You're rounding off to the nearest 250 milligram because that's about half a vial in most cases. And then the interval, not the dose, but the interval is determined by the renal function. In other words, if you have normal renal function, normally it'll be 12 hourly, sometimes even as little as 8 hourly. If your renal function starts declining, then it can be every day or every 2 days. And if it's less than 15 by your EGFR, you should really just give one dose, not write a maintenance dose, and only give the next dose when the levels suggest it's the right time, at least for many people. But so interestingly here, again, we're not changing the dose despite the renal function. We're just changing the interval at which I give the next dose. And that is there covered on this dosing table over there. And it makes sense. Remember that this is excreted renally. So if you have renal dysfunction, you're going to have issues with the excretion of the drug. And so you have to dose the drug a bit less carefully. But I haven't gone away from the central question, which is how do I measure, or how do I target that area under the curve of 400 to 600? The old way, until about 3 years ago, at least, was common, is to target a trough level. So the basic idea is we measure that trough level, which is easy to time. You know when the next dose should be given. If it's every 12 hours, usually it's 10 o'clock and 10 p.m. And you just before that next dose, let's say 9:30 instead of 10, when the next dose is due, you take a drug level, and that's the trough level. And then the idea was that that trough level is a rough guide to what the whole area under the curve was before that. And so if you target a trough level, you're going to mostly be okay with the area under the curve. We want an area under the curve of 400 to 600, but all we have is a trough level, but they correlate enough that in fact, if you measure a trough level, you will be okay. So you're measuring this trough level to estimate a minimum area under the curve. You have to wait, though, until you're at steady state. Remember that graph on the right of steady state. In other words, it doesn't help to measure a trough level here because that's not what your steady state is. You've got to wait until it stops changing, which is usually around before the 4th or 5th dose. And at that point, you're sort of roughly at steady state, and you can start to interpret trough levels well. So this is a fairly big disadvantage if you think about it, because you, for example, you're waiting for, so if you're giving it 12 hourly, that's before the 4th dose, that's before the end of the 2nd day that you can measure a trough level. It's the very first time you can do that. You might only get your result the next day, which is now day 3 going on day 4. So you might have been wrong for those first few days, which you can imagine is quite a big problem, but it was all you could do with these trough levels. You can't really interpret a trough level after 1 or 2 doses because you're well off the reference ranges. And then for severe infections, the trough level historically was between 15 and 20 micrograms per mil. For the less severe infections, people tolerated 10 to 15. And the reason for that is really this graph over here. So this is from PalmCrit, which is a nice website for some of the pharmacology part as well. And if you say took 15 as the minimum, right, which is where this trough level of 15 would suggest, and you times that minimum by 24 hours, then you end up with 360. So in other words, remember, I'm targeting 400 to 600. So I get at an absolute minimum 360 just by getting a trough of 15. And then these blue bits, which are the parts above it, in other words, where you give a next dose and you wait until it hits the trough, they would add a bit, and that bit was pretty much always enough to take you over 400 because you were 360 already with the green. Now if I add a few of the blues, well, I'm already over 400. And so you can see kind of a problem here in a way that would portend the future. The 15 as a minimum, say 15 to 20 as a trough, let's say 15 at a minimum, that is almost always fine for the minimum area under the curve for this reason. But you can see the problem here. It might be a lot worse in terms of the total. In other words, the area may go well over 600, even if my trough is sitting at, say, 15. Because who knows how tall these peaks are. If these peaks are very tall, well, I might push it well into the nephrotoxic range. So really what the trough level is doing here is targeting efficacy more than toxicity, although the maximum of, say, 20 as a trough is helping out a bit for toxicity too. So it's not a great method, but it's all we had for a very long time. So I want to compare these methods by giving you a worked example in each case. So I'm going to use the exact same patient for each of the methods. This is a hypothetical 41-year-old female who weighs 62 kilograms. His creatinine clearance is 69 mils per minute. He's critically ill. He's got a bad staph infection. He gets a loading dose, and now he's being given a gram 12 hourly. That's roughly what you would expect based on the maintenance dosing there as maintenance. So he's getting the right sort of dose based on the best guess you have. Remember, using the trough method for these severe infections, I'm aiming for a trough between 15 and 20. Okay. What happens, in fact, I get a trough back of 12.5, which is a bit too low. Now, you could guess roughly, and you could say, well, that's a little bit off. I could probably go up by, say, 250 and make it 1250, 12 hourly, or maybe 500 and make it 1500, 12 hourly. But in fact, there's always been apps that can help you do this and estimate that. So I'm going to punch them into an app that can do all 3 methods that I'm going to show you just so we have some comparison. And on this app, and I'll give you the reference at the end for this, on this app over here, I just want to draw your attention. I'm saying I want to target a trough of 15 to 20. Here's my 62-year-old, so 62 kilogram person. And he's based on one level getting 1,000 milligrams every 12 hours. The trough level was 12.5, and it was just half, and it was a proper trough. It was half an hour before the next dose. So I took this, say, at 9:30, just before the 10 o'clock dose. So if you punch that into these sort of apps, the recommendation based on getting a trough of 15 to 20, in this case, was that we change the dose to 1,500 milligrams 12 hourly. And that, according to this app, would suggest I'd probably get a trough somewhere in the middle of 15 to 20, of say 17.8 in this case. And I would have achieved what I'm trying with this method. I want to get a trough of 15 to 20. So I've tried, and now my suggested dose is 1,500. So success, right? Maybe. That's certainly better than not having a level. But you can see the problem a little bit if I draw this graph. So here's my first hypothetical graph. and I've got a trough level here of say 12.2, and the area under the curve is that. Great. But if you think about it, if I only have one trough level, how do I know it's not this graph, for example, in a patient who maybe had a lesser peak and excreted a bit quicker, and they had a totally different area under the curve? So you can see the problem. Again, I don't know, I have no idea with a trough level which of those two graphs it is, or which of any one of an infinite number of graphs it really is with roughly that shape, because I don't have a second measurement and I don't have anything else, any other data to go on. So a few years ago, probably about 10 years ago, many of the first the high-income country pharmacology departments started moving to the second method here, which is to estimate that area under the curve using simple pharmacokinetics equations. It's called the trapezoidal method because of what happens when you plot it on a log graph, but it doesn't matter. The point here is that I'm using basic sort of pharmacology to say, if it's here and here, I can draw a curve based on what I know about pharmacology between 2 points. So you need two measurements for this method. You need to measure a peak now, somewhere near steady state. So again, I've got to wait at least 4 doses, say 5 doses, before I'm measuring this. And I need to wait, once I've given it, so say I infuse the dose over an hour for 1,000 milligrams, I need to wait an hour or two after that to measure the true peak, because it's got to have had a chance to distribute into all the various components of the body. And then I measure a peak, and then I measure a trough again. Remember, the same way I measured the trough before. Ideally, during that same dosing interval, so I haven't added another vancomycin dose in between, but you don't have to, but ideally if it's within the same dosing interval, that would be great. And then I use these basic pharmacokinetic equations. Again, I'm not using them, I'm giving them to the app, and it's using them. But any pharmacologist could tell you roughly these clearance equations, and you can measure and estimate at least the area under the curve. For the microbiologists here, all of these guidelines suggest using an MIC of 1. For a technical reason, if you're not a microbiologist who knows what this means, you can block your ears for 20 seconds. But basically, the reason of just assuming 1 is a couple-fold. One is that it may take too long before you have an actual MIC ratio, MIC value anyway. Most MRSA isolates have a very narrow range anyway, and it's somewhere around 1. And in fact, even by broth microdeletion, which is the method they suggest, the MIC values are still imprecise when you look at many of the things in the literature. So basically, for everyone, you're estimating 1, more or less, unless you happen to find by broth microdeletion an MIC even higher. And then when I have 2 levels, I know now it's, say, that peak. So I've got the same trough, imagine, but I've got this peak, not the other peak. And then I plug those 2 pieces of data into these equations, obviously done by an app, not done by you. And then it can say, okay, roughly the area under the curve is that one in red, say, if I had the peak that I had. I hope that kind of makes sense conceptually, obviously not going through the individual equations. So let's see what happens. Now we've already had one answer from targeting the trough. What about this method? So I'm going to have the same patient. This is the same 41-year-old male, critically ill. He weighs 62 kilograms, creatinine clearance 69. We give him a loading dose. I give him 1,000 milligrams 12 hourly as maintenance. And somewhere near steady state, I decide I need to measure this level. I'm going to use this different method, and I'm going to target an area under the curve of 400 to 600. In this case, his peak was 24.3. And the trough was 12.5. And by the way, I've modeled these patients identically. So the peak actually was almost certainly was the best guess for the peak from the first patient too, but we didn't measure a peak. So in this one, I'm delivering this dose at about 10 o'clock, between 10 and 11. I'm waiting an hour, so now it's midnight, and I'm measuring the peak. Trough just before the 10 a.m. dose the next morning, I'm measuring a trough. Those are the values. That 12.5 trough is the same value as in the first case, right? And what if I plug it into these equations? Now I'm saying I want to target here an area under the curve to MIC of more than 400. That's better because I don't want to target a trough. I want to target an MIC. And I put in those details in the red there. Here's my trough. Here's my peak. Here's my trough. And it's 9.5 hours between the first and the second level. And then what happens from this machine? Well, it spits out a very different answer. And that's the first thing that should surprise you. Remember, I was on 1,000 milligrams 12 hourly. The first method suggested I should increase that to 1,500 milligrams 12 hourly to target a trough level. This method suggests, in fact, I should decrease it down to 750 milligrams 12 hourly. And they say that with that method, my area under the curve will be 494, they reckon, and that's comfortably between the 400 to 600 zone. So we're doing well. Now, what does that suggest? It suggests that it doesn't not caring about the trough is helpful here, because the trough level may well be less than 15, but it doesn't matter because we're not actually targeting the trough, we're targeting the area under the curve. So with that peak and that trough, this calculation suggests we're good at a lower dose than the patient was getting, let alone a higher dose. Now, I have chosen scenarios where these methods do give slightly different results. Sometimes they're not that different, so I don't want to alarm you too much. But the point is, this is not that untypical of a scenario, and these results are very, very different already with these two methods. So how about the third method? And the third and most complicated method now. And we're almost there. This is to use this Bayesian method. The Bayesian method, the clever thing about this is it's basically using not the pure pharmacokinetic equations, but rather actual patient data from other populations that's out in the literature. So they've taken patients who are obese, and they've taken patients who are critically ill, and they've taken men, and they've taken women, and they've taken a whole bunch of groups of people. And they've seen what actually happens, not using the equations. And then you plug in your results and it'll adapt. So that's the prior, effectively, what the results is from the population. And then you plug in your actual results, and then you get the posterior. So it'll effectively adapt the equations dynamically to fit what your results are. And the nice thing here is you can measure, well, you probably should measure two, but you can get away with just one, just a trough level. And a bigger advantage is I don't need to wait until steady state. In other words, I don't need to wait those 4 half-lives until I can start measuring it. That, to my mind, is a big advantage, because I can start figuring out if I'm right and wrong with my guess in terms of dosing very much sooner. You do have to just tell the model if you're using a generalized hospital patient or a critically ill patient or extremely obese patient, but it can get there. So again, the advantages are it's the most accurate measure of the area under the curve for complicated reasons. You don't have to be at steady state, and you can use a single drug level. Although probably for patients such as the obese and critically ill, you probably, just to make it more accurate, because you should use 2, but 1 was not bad. So if I have the exact same patient who's 41 years old and he weighs 62 kilograms and he's etc., and I have the exact same target and the exact same peaks and the exact same troughs as the previous 2 patients, what does this suggest? I plug it into the app and I put the same details in, and it suggests a third answer, which is 750 milligrams 8 hourly. And its predicted area under the curve here is 493, which is helpful, between 400 and 600. So I have 3 different answers. And I must stress, you don't always get 3 different answers, but in this case we do. And this is not an implausible case. And now I want to show you them in the table using this Bayesian predictions as the best case, or the best guess we have. So for example, in the current dosing, I was giving this patient 1,000 milligrams 12 hourly. The trough I got was 12.5. The actual, if you plug that into the Bayesian equation, it suggests that my area under the curve is 421, which is not bad, right? I wanted 400 to 600. It's a bit close to the bottom, and obviously there's some error in this because you're always estimating. So it might not be the very best, which is why I chose a different option, but it's actually not bad. The trough method, targeting the trough method, actually, by changing to 1500, the Bayesian method suggests I'll get a trough about 18, but I'm going to push this area under the curve well over the 600, which is going to cause more nephrotoxicity. And it's really not helpful here. Whereas the area under the curve method, using those PK equations, those simple ones, the second method, it suggests over here, they suggested I'd get 494, but the best method, the Bayesian method, suggests, in fact, that's not true. I'll probably be under 400, which means I run the risk here of getting decreased efficacy. Interestingly, if you look at the trough, it predicted it was 9, which would have panicked anyone more than a few years ago, because you look at that and you say, oh my goodness, you're nowhere close to 15 to 20. I need to up it. And in fact, you do need to up it, but not nearly as much as you would think, because that's not the thing to pay attention to. And then if you use the best method, you end up with this dose here of 750 milligrams 8 hourly, suggesting over here that you get more comfortable. It's a bit more comfortable above 400 area under the curve, but you're not going above 600, so you're not going to put the patient at big risk of this. So if we just left the patient alone, we would have got a not bad result. But in fact, this Bayesian method suggests, well, there's a way of doing it which you're slightly more likely to get good outcomes for. And the nice thing about this is you can see these programs give you a range of options. So you can see, for example, here's 8 hourly, and there's, if I chose 500 or 750 or 1,000 or 1,250, here's the area under the curve that I might get. And in green is the only one which you could choose. And then if I dose it, say 12 hourly, there's a couple which you could have chosen, which would have given something in the target. So you can see a range of options because sometimes just more suitable to dose someone 12 hourly than 8 hourly. So how do we summarize all of this? My big thing is I don't think you should target a trough anymore. You might measure a trough at maybe all you have, but I don't think you should target a trough. You should try and turn that trough into some estimate of the area under the curve. And really what we want is this range between 400 and 600, usually assuming an MIC of 1, which is usually a pretty safe assumption. The best method is this Bayesian method. The nice thing is you don't have to wait for steady state. So I can collect samples really. If I start the patient today, I can collect them from tomorrow. I should probably have peak and trough, but in fact, I just do trough because it's really logistically quite difficult to get it. And you might be able to get away with just a trough level in many patients, like I said, but these patients, we just haven't studied them well in critically ill patients and obese patients and patients with unstable renal dysfunction. So for those patients, might be slightly more accurate to use 2, but it's not far off if you use 1. So I'll show you this at the end. And what we do at our hospital at the moment, we try and use the Bayesian method. We mostly just use troughs because we've battled to get peak and trough in the same dosing interval. It's difficult because it's over a 12-hour period. Often it's not easy. If you don't get a true trough, don't worry. The software can deviate, can tolerate that sort of deviation as long as you know what time it was taken. So if it's taken too early, you can usually compensate for that. And we've been able to start doing these trough levels before day 3 or 4, which is pretty handy. Obviously, bear in mind that we do see them from an infectious diseases perspective for pretty much every MRSA case and most, at least, e-fecal. So I have a few minutes left, and I'm going to give you a second to look at these as a brain break before I give you the final summary version of this, because there's 1 or 2 nuances I still want to cover in 5 minutes at the end of this. So which antibiotics do these refer to? Have a think for a second, and I'll show you something totally different, I promise. This is the ID emoji game. And the answer, of course, just to get you warmed up, is flagell, as in flag ill. And then the one on the bottom, if you can see me for an infectious diseases fellowship post. That is amphotericin B, amphotericin B. And you can see what wonderful jobs you have and what great job satisfaction you have in infectious diseases. And on the right is my all-time favorite of doxycycline. Okay, pause, think. I'm going to have one last push at the end. All right. There's one way around this if you don't want to measure any of this stuff, and that's just to give it by continuous infusion. Now, many people in ICU do get it by continuous infusion. You do get the target concentrations a bit more rapidly. It doesn't appear to be any mortality benefit to doing that, though. Might be slightly less nephrotoxicity. Some studies, they're all really observational, have suggested benefits. Some have not suggested benefits, not clear. The big disadvantage, of course, is you block up that line for the entire time, so which makes it incompatible with many other drugs. It is incompatible with many other drugs, and blocking up one port, for example, can be problematic. But if you can tolerate that, you can see the kind of idea. This is a continuous infusion, so instead of getting that jagged seesaw look to it, you just get it up to a level, and then you're giving a constant amount, the same amount that you're excreting. And so you just get this flat line, which is really easy because then you don't use any strong calculations to work it out. Just be aware the loading dose is different, the maintenance dose is different, and the steady state concentration you're targeting is different. And there's no peak and trough, it's just flat. So in other words, don't use the values we've shown you from the previous things. Just look them up if you're not sure. They're just different. But you can kind of see the plan. Once it's steady state, it's easy to work out. So once it's flat, you just make a rectangle of that. And you say, here's my level, and I times that by 24 hours, and that's the area under the curve. It's no horrid six or things and exponential decay or anything funny like that. It's really straightforward. You just have to target a different level. So I want, for example, if I target a level here of 20 to 25, that'll equate to 480 to 600. So I have 1. So this is one way around that complexity, which means then if you want to compare the levels, you really have these pluses and minuses for each of them. Trough level is easy. You don't need a calculation. It's 1 level, but it really is poor proxy for the area under the curve. You don't usually sacrifice efficacy, but you often exceed the toxic level unnecessarily if you target a trough level. You need to wait for steady state too. If you use those PK equations, you need 2 levels. Unfortunately, you can't do it with 1. And again, you need to wait for steady state. And then if you use my favorite one, the Bayesian method, it's the most accurate. It can work on a single level, which is handy for us. And it can be done long before steady state, which is really handy. And then the way to run an end round around all of that is this continuous infusion, where it's a really simple calculation, and you can just target a particular level. Just remember, all of the dosing is different. The loading dose is different. The maintenance dose is different. And the level you're targeting is different because it's not a peak or a trough. It's just a random level. Just the downside there is that it requires a dedicated intravenous line. May not work, for example, in the general wards. And then one slide really lastly about this intermittent dosing. Again, my advice here is just to look it up, but I want to show you the concept. The loading dose is the same. Maintenance dose is lower, and we're assuming I'm giving it 3 times a day for intermittent dialysis because the patient's getting dialyzed, say, Monday, Wednesday, Friday. I'm giving these doses after dialysis, clearly, because you do dialyze a lot of it off, especially with these high permeability dialysis membranes. And then you're checking the levels before dialysis. And again, the level's a little bit different. I'm actually aiming for that old level of 15 to 20 because, again, it correlates with an area under the curve of 400 to 600 in the last day. And then it will mean the area under the curve for the previous days when I haven't got dialysis even higher, but we don't really care because these patients usually, it doesn't matter if you have nephrotoxicity, and the majority of them with the chronic dialysis because they've really lost their kidneys. Intermittent hemodialysis is probably as good as you can do, though. And then you just measure the levels once. So the concept here, again, is that you're doing something at least weekly. And then I wanted to end off with really just saying, what does the future look for this? And I think the future looks like you don't use vancomycin is the short version. Any drug that's this complicated to dose is clearly suboptimal. Where I worked in the US, if you write vancomycin, even the infectious diseases doctors don't write the dose. You just say, I want the drug. And then an individual pharmacologist pops up like magic and they start calculating all these parameters for you and putting it in for each individual patient. That was with an incredible pharmacology team specialized in infectious diseases pharmacology, where they could literally have one-to-one for each patient who needs it. This is totally not doable in many settings. So I really think it's suboptimal. On efficacy, sadly, no drug has beaten vancomycin for MRSA. There's no better therapy. You get non-inferiority sometimes, but no better. But I just think those studies are done in real near ideal settings, either in clinical trials or even if it's observational data is done in high-income countries. What would the results be in low and middle-income countries is really not well studied. And I do think this is a big research gap. It's not that easy to study, but I do think you need to study it in a scenario where levels take time, where nursing care is more erratic. I think if we look at the levels of vancomycin, the time we have in the target range in our setting, it's low, and that's with infectious diseases looking at the patients. So what are the other alternative drugs? I think you have to go for other drugs. There's quite a few, and I've got them on the table, but I just want to highlight 2 of them. This ticaplanin, which a Cochrane meta-analysis suggests has equal efficacy with fewer side effects. America doesn't have it, so it's not well studied, and therefore it often doesn't fall in guidelines, and it doesn't get studied by RCTs, but it's available in South Africa. You probably sadly need levels for that too, but they're not nearly as problematic as the levels for vancomycin. I'm not sure how easy they are to get in South Africa because we don't have them in the state sector, but it's not as bad. It's a kind of plus minus for severe infections, and you don't have any level checking required for moderate infections. It's a lot better than the vancomycin scenario in terms of monitoring. And it's a very, very similar efficacy. And the other one really is this daptomycin, which is in the US, is getting quite well studied. It's non-inferior in a small RCT. Most of the data, unfortunately, is observational, which means that in many guidelines, it's not the front, it's kind of an alternative to vancomycin. But from what data we do have, it appears to have reduced risk of clinical data compared to vancomycin, and fewer adverse events, mostly from observational data, though. And the point is, at very least, these appear to be in the ballpark in terms of efficacy. And you don't have to monitor levels at all with daptomycin. If I look at those 2 options in terms of price using the single exit price, and bear in mind the state tender price is usually lower than this. So, for example, if they did get on state tender, it would be lower. Vancomycin is cheap. Ticaplanin is not that much more expensive, though, and it's a typical daily dose for severe infections. Daptomycin is quite a bit more expensive, but even that's not horrific. In these cases, each time modeled on a 75 kg person. So, in summary, sadly, monitoring with intermittent dosing of vancomycin has gotten trickier. I do think it's worth the effort. It'll likely reduce nephrotoxicity in these patients, which can be up to nearly half of patients compared to not giving vancomycin. If you happen to be giving it continuous vancomycin infusions, you're safe because it's still very easy. You don't have to use any of these funny equations. Just remember that the levels of everything are different. So we often see the mistake in ICU where the patients come back, the standard lab form gives the interpretation of a trough level for vancomycin level, but you remember that that's not appropriate for continuous infusions. So you have to use the right target. But again, if you do that, if you just remember that all the levels are a bit different, you really don't have this problem in terms of using funny equations. In resource limited settings, I am convinced, although sadly don't yet have the data, one day hopefully someone will find it, that our outcomes are not nearly as good because of these enormous challenges with vancomycin. So I think it's worth looking into as a research priority. I also think you might just take the plunge with some of these other drugs, especially something like ticaplanin, which is not that expensive. And that's it. I want to leave you with this page. I'll just leave it on here. These are some free Bayesian pharmacokinetic tools. The first ones you had to pay an arm and a leg for because it was proprietary data and everyone kept them. Fortunately, some good patriots have managed to create free versions using some very good Bayesian data. And you can find two of them there, the two that I use. I use the top one actually mostly. But if you get this, you can plug your details in. It's a bit more complicated, but it takes getting used to for the first 2 or 3 patients, and then it's easy. There are the guidelines which have been written in 2020 about how to do this in much more detail than I've given. And I've skimmed over some of them because of just an interest of really just making coherent talk rather than going into every detail. And then for those who do want to play the antimicrobial name emoji game, which I strongly recommend, as all good ID nerds do, that's a website you can enter, and you can find, I think there's 22 of antibiotics as described by emojis, which you can send to your friends to annoy them. I'm going to leave it there, but I've got a couple of minutes. I'm very happy to take questions. So thanks very much. Okay, I'm going to pull up the chat. Okay, first comments about the apps. I've got that on the table. I'm just going to leave it over there. And then you were measuring Toby. So yeah, so I think so I've covered that, but I think probably after you typed it in as well. So you don't need the Bayesian method for continuous infusions because it's just really simple. You basically just take the level once you're at steady state, which is quick with constant continuous infusion, and you times that by 24, and that's the area under the curve. So whatever level you get times 24 is the area under the curve. And then you target the 400 to 600. And you correct that those random levels, the target there would be lower. So let me, in fact, I'm just going to go back to show you. Oops, sorry. Let's go back to show this one. So there, if we're targeting 20 to 25, you end up, because you just times that by 24, you end up with an area under the curve of 480 to 600. And so there you're in that target range, which is exactly as you've said. Can the same Bayesian approach apply to IE? Yes, that's the aim. So we definitely do want to use it for these complicated patients. Sadly, with a lot of these Bayesian things, you don't get the perfect answer with, like, there isn't this patient who is obese and has endocarditis and is African American, and so there's some limitations to that. But anything you do will be better than what you have. To do it. There's a question about the volume of distribution in the Bayesian formula. So you don't need, so it will estimate for you. That's the one huge advantage of it. So it's basically saying you've entered, say, 2 levels, you've given them a peak and the trough, and you've told them basic facts about the person, like their age and their sex. And you've said, I want to model this on a sort of critically ill population, and it will estimate the volume of distribution for that. So you don't need to enter it. Which is a good question. And then there's a question which is on the direct message saying, in a resource limited area where therapeutic drug monitoring is not possible, the results are delayed, which method would you recommend? So this is the problem with vancomycin, right? In a resource limited setting where therapeutic drug monitoring results are delayed, I would try not to use it. The problem is we don't really have that option, as certainly in the state sector, where no one is buying ticaplanin or daptomycin for us. So it's really, you're stuck with vancomycin. If you bear in mind that you have to use them, even if they're delayed, well, then you do as best you can. And I would use the Bayesian method because, again, you can use it on just a single trough. And I would use it. I think it's better there than targeting a individual trough level. I must be honest, in our setting where the results take 24 hours, what we usually tell our teams is just keep sending them, because in fact, often it's quite dynamic. Today the patient's trough is that, tomorrow their renal function's gone off and their trough will be different. So we're always a day behind, but at least we're only a maximum of a day behind if we just say send a daily one. In theory, if you're in a place where you can get these results quickly, where it's not going to take you, where you're not always a day behind, you don't have to do it every day. Clearly, you just have to do it. And then if the renal function changes, we suggest doing it again at that point. Because remember, of course, the renal function is the big marker of whether, how much excretion the drug has. So you could keep it constant until that point. One other thing I didn't really go into, but in these Bayesian models, you can actually account for change in renal function too, which is handy. So it's much more dynamic, which is one reason it's more accurate than those static PK equations in the second method. The question is, do we adjust dosage according to MIC once it's ready? It's a good question. So I wouldn't unless the MIC is more than one. It's a short version. And the reason really it was given, and I was really brief about it, but if you are confident that the MIC is way lower, I guess you could use that. But I would say the only reason really to change the MIC assumption of 1 is if it's much higher. And the reason really is if it's a little bit low, it's very hard to be sure it's not, say, 1 using the optimum methods. And even if you do, there's a lot of variability, which has been documented in many studies. And some of the microbiologists in the call maybe have, better insight or be able to answer that question a bit better. But I think unless you think it's more than 1, I would use just 1 as your number, which makes it easy because you just target 400 to 600, and then you don't worry about the MIC effectively unless it's more than 1. Okay, sure. There's a lot of the question. I'm just going through. Some of them are sent on private messages. Some of them are sent on WhatsApp, which is a lot more challenging. But we're a little bit over time, so I'm going to end there, I think, unless there's anything. I think I've gone through at least the chat ones. If there's any of those of you who've WhatsApped me, I'll WhatsApp you when I can and give you the results for that. But I think I'm going to end there just because we just over